Good morning, everybody. My name is Brooke Phillips. I'm Marketing Manager for Shield Healthcare. My name is Brooke Phillips. I'm Marketing Manager for Shield Healthcare, and I'd like to welcome you to today's webinar on Incontinence-Associated Dermatitis, Assessment, Prevention, and Management. Before we begin, just a few housekeeping items. All attendees will be in listen-only mode. If you have a question, please type it in the question box on the right-hand side of your screen. A PDF of the presentation slides is also available as a handout that you can download right from the webinar. If you registered as a healthcare professional and would like to receive CE credit, look for an email from Capital Nursing Education containing your CE certificate within 5 to 7 business days. If you're watching this presentation as part of a group, please download the group CE handouts from the webinar panel in order for everyone in your group to qualify for CE credit. If you miss any portion of this presentation or would like to share it with a colleague, the webinar is being recorded and will be available on shieldhealthcare.com/community by the end of the week. I'm delighted to introduce Kelly Sparks this morning. Kelly Sparks, RN, BSN, CWOCN, CFCN, as our presenter today from Capital Nursing Education. Kelly has been a CWOCN for more than 25 years and a nurse for more than 30. She's worked in wound, ostomy, and continence care for most of her career. Kelly has been on the board of directors of the Pacific Coast region several times in the past and on multiple projects for the WOCN Certification Board. She is active with the local Sacramento WOC Nurse Group, where she serves as secretary. She is recently retired from Dignity Health, but continues with her private practice. Kelly has been a speaker for many different conferences and classes. She enjoys speaking for Shield webinars and working with Capital Nursing Education to help promote clinical education necessary for the care of patients. At this time, I'd like to pass this presentation over to Kelly. Kelly, it's all yours.
Thank you, Brooke. Thank you very much, and good morning, everybody. Today, we're going to look at this incontinence-associated dermatitis, assessment, prevention, and management. So the objectives of this program are in front of you, but I'll go over a few of them. We're going to become aware of the different types of skin damage that can result from moisture, review the skin anatomy as usual, and develop an understanding of the MASD, or moisture-associated skin damage, assess the skin for moisture damage, explore the ways to prevent IAD, and to learn how to treat incontinence-associated dermatitis. So there are several things here that have to do with moisture-associated skin damage. First one that we're going to focus on mostly today is the incontinence-associated dermatitis. There's also intertriginous dermatitis. Some people say intertriginous, so however you plan to say it, that's fine. Peri-wound moisture-associated skin damage and peristomal moisture-associated skin damage. So we'll be looking at all of those briefly, but mostly concentrating on IAD. So just a little review of the anatomy of the skin. We have, of course, the epidermis, dermis, and adipose tissue, muscle, and bone. I love that picture from the National Pressure Ulcer Advisory Committee. It's a great picture. But I want to get a little bit more in depth in that the outermost epidermal layer, the stratum corneum, is made up of keratin-rich disc-shaped horny cells called corneocytes. And they are connected by the rich lipid substance that forms the strong barrier. Skin is acidic. It's approximately, its pH is approximately between 4 and 6. And that helps control the bacteria that's on its surface. This acid mantle maintains a cohesion and barrier function of the stratum corneum. So prolonged exposure to chemicals, irritant chemicals such as urine and stool, can raise the skin's pH, and that damages this protective acid mantle and disrupts the barrier function. So when the barrier function is disturbed, then the skin becomes susceptible to the enzymes of the urine and stool, resulting in inflammation, erythema, and denudement. So as we look at how important the skin is, besides that providing the interface between the body and the rest of the world and shielding us from organisms, it protects us from physical and mechanical injury, but also it's strong enough to protect us, yet flexible enough to move with us. So that's one of the best things about it, is that it is pretty flexible if we take care of it. Function of the skin. We've already talked about the protective barrier and the prevention of loss of moisture. The skin also reduces the harmful effects of UV radiation. It also acts as a sensory organ, such as, feeling a baby's soft face. It enables you to be able to feel that or to feel the loving touch of your loved one. It also helps to regulate the temperature control and also does play a role in the immunological surveillance. So vitamin D3 also is sensitized in the skin. And, of course, the cosmetic and social and sexual associations as well. So skin functions in many different ways. And, of course, without it, what would we do? We would fall apart. So we love our skin. We need to take care of it. This bodies the exhibition. I absolutely loved that. It was called Body World Exhibition when we went. And it was so interesting because they plasticized, and that's a technique where they process. It's a process that they go through where they the water and fat are replaced by certain plastics, and it yields specimens that can be touched. They don't smell, they don't decay, and they even retain most properties of the original sample. So I never thought about how big our skin was until I went to this exhibition. It was so interesting. And here was this man, and I tried to put this on the slide, but it is a little bit fuzzy, but you can look it up under bodies. And it is incredible that they removed all the skin and just laid it over his arm. And it just really hit home as to how our skin is our largest organ. Weighs between 6 and 8 pounds, covers more than 20 square feet. And of course, that depends on your size because the skin is going to grow when the body grows. So you definitely have a lot of skin. Again, the pH we already went over, and the thickness from 0.5 millimeters to 6 millimeters. Of course, that depends on where it is. Your eyelids are the thinnest, and your palms and the soles of your feet are the thickest. It's very, very interesting, that exhibition. I just absolutely loved it. The layers of the skin. Epidermis, we have definitely our physical and chemical barrier, like we said, keeps the body fluids in, but it also allows air in and moisture out. Again, the acid pH around 4 to 6. And then low amounts of water with that acid pH make it hostile to those many microorganisms. So new cells will start from the bottom layer and work up, and they change in composition slightly. When they reach the upper layer, they die and slough off. And of course, if you don't cleanse well, this dying and sloughing off doesn't work well. And sometimes you can have a patient that has a lot of dead skin that needs to be cleaned off. So sometimes we have to really get, really clean deep in order to get some of that old stuff off. The dermis, it contains the blood vessels, the connective tissue, the nerve endings, hair follicles, sweat glands, and the main function there is the tensile strength, along with the epidermal support and moisture retention, blood and oxygen supply to the skin. And then the subcu tissue is made of fat and connective tissue. It does provide the cushioning. And you can see with some of the elderly people that we have that adipose tissue decreases, and they don't have that cushioning that the younger folks have. So we're going to look at moisture-associated skin damage, and this term is what we use to describe the irritation, inflammation, erosion of the skin that has been in contact with some type of moisture. So we'll be talking about each one of these, but again, we're going to kind of focus on the IAD. So with that being said, skin assessment. All right, I'm not gonna go into the entire skin assessment technique because most of you have already learned that and have been doing it for some time. However, I want to go over some of the very simple and commonly forgotten assessment tools. I really like this saying, for one mistake for not knowing, 10 mistakes are made for not looking. That really does stand true. And just kind of think about that when you're doing your assessment. It makes a huge difference if you do not look at your patient's skin. On a skin assessment, you want to inspect the entire body, including the skin folds, check under all devices, etc. Palpation and touch, we're gonna talk about that. You want to note the temperature changes, the edema, whether it's wet or dry, and then again, use your nose. There's lots of odors and smells and you need to use them to determine the source sometimes. And also document. You want to document your findings and, of course, notify the physician if you find anything abnormal. When I say inspect the entire patient, I mean the entire patient. You'd be surprised what you can find. Many of you that have heard me talk before might have already heard this, but I just need to repeat this. I was in a skilled nursing facility years ago, and I was called to come and assess this patient's bottom. Okay, she obviously had some pressure injury they wanted me to look at. So I went to this facility. She was sitting in her wheelchair. She was in the eating area, and she had been sitting there for a while. So the aide came and helped, and we brought her back to her room and put her in bed. And I was assessing her skin from head to toe. Well, you never know what you might find. As I'm looking in all the creases and crevices, all of a sudden there's something underneath, kind of on her hip, but under a skin fold. And I pulled it out and looked at it, and I was like wondering what that was, and the aide was standing there. And I said, "What is this?" And it was moldy, and it was gross, and there was something between the mold. And the aide said, "Last week we had ham sandwiches. Looked like a half of a ham sandwich tucked underneath her fold." It was horrible. It smelled horrible. They thought that her wound on her bottom was what was odoriferous. Well, her bottom did have a wound, but it wasn't nearly as bad as that. And the skin around it, oddly enough, was not damaged by that sandwich. So just really keep in mind that you really have to look at every inch of a patient's body. And like I said, you don't know what you're going to find. So you also want to look at everything in areas that are red, discolored, not intact. Redness, erythema, it shows up better on lighter skin. Darker skin looks almost brown to maybe purple, might have a black hue. So really look at what you are seeing. And document, of course, what you're seeing. You never know what that might be, and so it's important to take a really close look. What do you hear? Okay, sometimes patients come into the ED and they're admitted to the hospital, might have only a small area of warmth on the heel, for example, and within the next 48 to 72 hours, it's purple. It's purple maroon. You have a DTI. Well, it's important to listen to the family, because the family might tell you that they found the patient down on the floor or in a chair, or they coded in the field. I mean, you listen to what's going on around you, and also what the patient is saying. Are they itching? Are they burning? Do they have pain? A lot of times a DTI, or deep tissue injury, it can take 48 to 72 hours to surface. So by discovering that on admission, then it is not a hospital acquired. So very important to do that assessment and make sure that you can actually get that noted in the chart right away. Then what do you feel? Okay, there's different things that you can tell by feeling. You can feel warmth, that again, may be an underlying issue such as a DTI. Maybe that DTI hasn't declared its full amount of destruction. You can feel if there's a lack of circulation to any limb. You can feel if they're inflamed. You can feel if it's scaly skin or if it's tight, or if there's any problem areas. Sometimes you can even feel pain, and that sounds funny, but you can feel heat over an injury. It's difficult to tell skin color in the darker skin, so it's important to feel. Sometimes if it's hot or cold, either hotter or colder than an adjacent area, then that gives you a hint that there's something going on there. It's important to feel for calluses and other disruptions in the skin that may not be visible to the eye. So don't be afraid to examine your patient with your other eyes, your fingers. Your fingers are your other eyes. Then you got to think about the smell. What do you smell? There's many different odors that those of us who've been in the business for a while have learned to recognize. For instance, I can usually smell Pseudomonas down the hallway. I can also tell when someone has a yeast infection before I even look. I can smell that musty odor. A lot of nurses can tell C. diff. Boom, that patient has C. diff. Or boom, that patient has blood in their stool. You can smell these things once you learn, and you won't forget those odors. I can tell when somebody has cancer or a fungating tumor. A lot of people can. So really think about what you're smelling. And these are things that mostly come automatic, but if you're new to the business and you're new to assessment, just keep in mind what you smell, and you will learn from that. Okay, let's talk about intertriginous dermatitis. This is when two skin surfaces might rub together. It can cause a lot of pain and discomfort, especially in the heat. So the friction in conjunction with the moisture can rub it raw. And we've seen this happen a lot with people in their skin folds. It can set up a beautiful environment for candidiasis. So you want to really look at these areas. And the inflammation, of course, is that trapped moisture and the rubbing that can really cause problems with skin. And there's several different ways to treat that. One of the things is to keep it dry and avoid any friction between the two opposing surfaces. So you want to cleanse it either with foaming cleanser or something and pat it dry. And then antimicrobial wicking sheets called Interdry. A lot of us have used that in the hospitals. It's wonderful, wonderful stuff. We use it in home health as well. And you just put it underneath the folds or between the folds, and it helps to wick away the moisture. If you don't have that, pillowcases work pretty good too, but you have to change them very frequently because you don't want it to sit there wet. Antifungal powder is very good in these areas to help keep it dry. Ointments and creams, they're not real good in areas that are pressed together. That just causes a little bit more heat, I think. I like the antifungal powder. So I have another story to tell you. I need to tell you this. And you may have heard this before too if you've been listening to any lectures that I've done. I lived in Red Bluff for a long while, and I worked at St. Elizabeth. And I had a cowboy come into my office, and he said that he worked there, so it wasn't like a patient coming. He just came in and said, "Hey, I need some help here." And so he was saying that he had chafing in the inner thigh area and also around his scrotum, and it was really hard for him to say. Of course, he said balls. He doesn't know the word scrotum. And it was from riding his horse in the heat because, it gets very hot in that area. And he would sweat, and he got really sore. So even though ointments and creams aren't the best treatment in closed areas like that, what I had in my office at the time was calmoseptine. So I said, you know what? It's a moisture barrier. I said, you know what? Why don't you take this little tube of calmoseptine, it was a little sample thing, and use that in the morning before you go riding, and then if you stop for any reason, put a little more in, but try that. And so anyway, this was great because it really, really helped treat the friction. It stopped that friction, which was part of the biggest problem. And a little bit of zinc oxide in there, a little bit of calamine kept it from itching. And I became his new best friend. So it was kind of cool to have him really get some use out of it and have it help him so much. So peri-wound moisture-associated dermatitis, we've all seen this as well. It occurs when the wound drainage is sitting on the skin. It can cause this inflammation and redness, and of course the skin turns white, then it sloughs off, and then you end up with a bigger wound. It can be a real problem. So if the wound is highly exudating, then there's a chance that you're going to get maceration around it. And the maceration is defined, of course, as the softening and breaking down of the skin resulting in prolonged exposure to moisture. So the excessive amounts of fluid that sit there on the skin because the dressing is wet and it's sitting on the skin, that is what breaks it down. So it becomes weak and then it peels off with the dressing, or it just comes off when you clean it. It can be very, very painful for the patient, and it can be the cause of the discomfort of their dressing changes. So it's very important to keep this from happening. The treatment, the goal, of course, is for this maceration around a wound is to absorb the excess drainage. So you can change the dressing to a different dressing type that absorbs more if it's highly exudative. Alginates, foams, you can also, when you change the dressing, let it dry out a little bit and then apply a little bit of your skin barrier just around the edge. Make sure the dressing is inside the wound rather than on the skin. And then, of course, increase the dressing changes, the frequency of the dressing changes as needed to keep that area dry. So, and that sometimes is forgotten. They think, okay, I'm using an alginate or I'm using a foam. If you have that extending over onto the edges without some skin barrier, you're going to have maceration. So when you put even gauze in a wound, you need to make sure that it's in the wound and not on the wound edges, if you can possibly do that. Peristomal moisture-associated skin damage. That is around a stoma, obviously, and they get inflamed. It denudes, and when that happens, then, of course, your pouch is not going to stick. You're going to have more problems coming up after that. Around a G-tube, around any type of tube, you can get this MASD. It's very, very painful for the patient. So the etiology of that, of course, is the skin exposure to urine or stool. And you can see here there's some skin damage around this one as well, and we'll talk about that in a few minutes. The treatment is to establish why is this skin getting exposed to fluids. Obviously, you're going to look at the pouching technique and determine what will help this. In this picture, it is too large of a cut, and it is exposing the skin to the stool, and that's going to break it down. So you want to teach the patient to use correct pouching system and the method to keep the skin dry and intact around the stoma. So if you're not experienced with stoma care, you want to refer these people to an ostomy nurse because it's very important for them to keep their skin nice around it. I just recently saw a private patient who called me out of desperation for this exact issue around an ileostomy. And the ileostomy, the stoma was real flush. And with a flush stoma, you must use some type of convexity to keep the stool from, or the effluent from going underneath that wafer. So that was what his problem was, and I ended up getting rid of what he had and putting him in a product that actually had some convexity and allowed it to push down around the stoma and keep the stool coming into the pouch rather than behind. And we did use some paste as well. It was a very difficult case because he had been using the wrong size cut and cutting it too big, and the skin was completely denuded. I had to use some stoma adhesive powder. I had to use some paste. I had to build it up in order to fix the skin around it. So we used also some of the rings and really helped him a lot. And like I said, if you're not experienced with that, please, send them to somebody who is, because it can really change their life when they have that much pain around the stoma. Okay, IAD, Incontinence-Associated Dermatitis. This is also known, of course, as diaper rash and diaper dermatitis. We don't like the word diaper, but it happens. Inflammation that occurs when the skin is prolonged contact with urine or stool. This actually looks like IAD plus a little bit of I would say there's some yeast going on in there. They need to have some antifungal powder along with taking care of the IAD, which we'll go over in a minute. So there's redness, edema, and pain in addition to erosion. You can get the yeast rash and, of course, bleeding. So the picture on the left, that's the worst fungal infection that I had ever seen. As far as it was just so tight. There was no open areas at all. I mean, like the second one. But it just was so infected. It was so weird. This was a hospice patient, and there was about 8 layers under her bottom. She had sheets on a low air loss mattress, plus paper pad on top of that with plastic backing, plus a draw sheet on top of that with plastic backing. That was followed by a thick folded bath blanket, and then another paper pad with plastic backing, and then another cloth pad with plastic backing and a chuck. Then she had on an adult brief that was taped up tightly over an incontinence pad that went from her belly button to her sacrum. So this poor lady was just sitting in urine, and it was just heating up on her, something terrible. So after 3 days of antifungal powder and only one incontinence pad placed and a chuck, and with frequent changes, it was about 50% gone in 3 days. That lady was so miserable with that. It was horrible. Now, the second picture is a patient that was so denuded that the calmoseptine or any other moisture barrier would not stick to those areas. So what we did is use stoma adhesive powder, and it stings right at first, but it helps so much that it was very much worth it. And we crusted over the wounds, and then you can add your moisture barrier cream to that crusting, and it worked really well for that one. The patient had a Foley catheter in, otherwise we would have had them put one in at that time. And this patient then was changed every 2 hours and with her repositioning, and she actually healed from this. This was a horrendous mess when we first walked in the room. The third one is an example how a pressure injury can be started, the assist in starting with IAD and with maceration. When you have maceration over the bony prominences, and then she's laying on that, and it just sloughs off, and you end up with a pressure injury in that time. So the rash was cleared up with some antifungal powder, and treatment of the pressure injuries, we still had to treat those. But she did have IAD with a yeast infection as well, and then developed those pressure injuries, which is so sad because that could have been prevented, probably. So typical characteristics of IAD is usually over the fatty tissue of the buttocks, the perineum, the inner thighs, and the groin, consolidated or patchy formation, and usually covers a diffuse area shaped like a mirror image of the skin fold or linear area in the anal cleft. We see a lot there. Superficial or partial thickness in depth. If it extends into the subcu or deeper tissue, then you would change it as a pressure injury according to the WCEI. So that's usually when we would be calling that a pressure injury. So the management of IAD, for all patients with IAD, you're going to gently cleanse, of course, and pat dry, apply a moisture barrier cream, and check them every 2 hours. During the changes or repositioning, you can remove the moisture barrier that is contaminated, but you do not need to remove all of it. And I have seen aides go in and literally scrape it off down to skin and scraping off some of the skin as well. So be very, very careful of that. You know, if you want to assess the skin, which I can understand, you can actually use some of the cleansers will take it off, but also mineral oil will do the same thing. Okay, when it first starts to become a problem, is when the skin is just red and there's no breaks in it at all. That's when it's important to start treatment right away, as soon as you see that redness. And using a barrier ointment at least once a shift with incontinence episodes is recommended. It's also very important to check the patient frequently to make sure that they're not sitting in urine or stool. So, you know, not everybody waits 2 hours before they urinate or defecate. So, and then if the skin is raw, red, mildly excoriated, that's when it's important to apply a zinc-based ointment every shift and with every incontinent episode. Make sure, or please note, that it's not necessary, again, to remove all of that. And only once a shift, you need to remove it to assess the skin. And you can do that, again, with some of the cleansers or also with mineral oil. It really works well. And then severe denudement, that oozing, bleeding, and with the skin loss, you want to sprinkle your stone adhesive powder, let it make a crust, then you can apply your zinc-based ointment at least every 6 hours, if not more. Repeat that because it is extremely sore. That is so painful. And then fungal yeast rash, as you see there, you can dust it with an antifungal powder, dust off the excess, and then apply your barrier cream on top of that as well. And you want to continue that for at least 7 to 10 days. Again, some people like the ointments that are antifungal. Some of them, I mean, there's some barriers that are antifungal as well. That can work really well, but just I really, really like using an antifungal powder, and sometimes it doesn't have to be a prescription nystatin, which is expensive. There are antifungal powders out there that work just as well. They have 2% miconazole, just like your nystatin is. So they can be a lot less expensive in your hospital, especially. Okay, so let's talk about preventative skincare. We're going to talk about cleaning and moisturizing and protecting. And we've talked a little bit about that before, but there are many products that you can choose from. And you want to make sure that a cleanser is pH balanced. If you've ever seen someone who has not bathed in a long time, you can see that accumulation of the skin, the dead cells, and the excess body oils, and also, whatever else they've been in. I've found hair, everything else. Sometimes it takes a long time to get it cleansed. So you may have to literally scrape off some of that old skin. It's really sometimes hard to get that to come off. And you have to be very, very careful with that because you don't want to scrape their skin as well, but you don't want to disrupt their skin underneath. But seriously, there's you've seen that, a lot of dead cells and excess body oils that stick to the skin. It's hard to clean sometimes. Sometimes I have seen guys, especially guys, some women, that their legs are so filthy with, not really filthy, but the accumulation of, they put lotion on and then they don't clean it all the way off, and you get this horrible, horrible discoloration and layers of stuff. Sometimes I've just taken like Triad, put it on there, just put it on really thick, wrap them up with moistened chucks and leave them for a little bit, maybe even overnight. Come back and then clean, and you can usually get a lot more off of it. So if cleansers are too harsh or there's too much friction, you can have tightness, water loss, dry skin, cracking. It's really, really, it really opens your eyes when you can see that is going to be a wound when it starts doing that. So tight skin is going to break down really easily with the cracking, and it allows bacteria to get in there, which then you get an infection. So it's important not to use harsh cleansers. Friction on the frail elderly patient can really cause a huge problem with irritation, and that leads again to open areas. So skin becomes red and rough and very irritated. So you want to look at what cleansers you're using and make sure that you're not using something that's going to injure them. One of the Braden subscores is moisture. And as you probably remember, the interventions for moisture are in that Braden intervention area, states to use absorbent pads. Keep skin dry and clean, use barrier ointments, and never vigorously massage over bony prominences. That's extremely important. You want to protect your skin. You want to use the protection such as your barriers to isolate the skin's exposure to different elements. You want to use some changing them more often using something such as the Vasilex ointment or calmoseptine or remedy, any of those. Exposure to irritants and excess moisture from urinary or fecal incontinence is what's going to lead to your painful dermatitis and skin breakdown, and even pressure ulcers or pressure injuries, I should say. Barriers are very good. We need to always use them on our patients, but all barriers are not created equal. So petrolatum or Vaseline, it is good protection. It does help hydrate a little bit, and it does help avoid the maceration. It does create a seal on the skin, preventing water loss, but it blocks the skin from breathing. So that's one thing about that. Dimethicone, it has variable protection. It's good skin hydration and modest protection against maceration. And we're going to talk a little bit more about that. Zinc oxide is good protection. It's poor skin hydration. It doesn't avoid the maceration as well. And the con is that it is thick and difficult to remove and hard to monitor the skin underneath. Absorbent pads are very important. And there actually was some studies done that I think I might be touching on those a little bit later. We'll talk about that. But one of the things that's very important is to change them often. And the other thing is to use the ones that do not have a plastic backing if you possibly can. The body-worn absorbent product guide is at this address you see here, bwap.wocn.org. It is very, very interesting. It's very good, and it needs to be, you need to look at that. It's really a good, additive to your whole nursing career, because it does help you decide what should and should not be used on these patients. Moisture interventions, of course, we're not going to use diapers. We're going to use absorbent pads, keep them clean and dry, use your barrier ointments, and avoid vigorous massage. We already covered that. Association of IAD with pressure injury development. That is a huge, huge, very interesting concept, because, like I said before, it is definitely a precursor, can be, and it's very important to keep IAD at a minimum for these people. Pressure injuries, we know, cause severe pain, prolonged hospitalization, increased costs, and they are caused from pressure, shear, friction, and microclimate. So we're going to talk a little bit about microclimate. That term is used to describe the local tissue temperature and moisture at the body and the support surface interface. So excessive moisture or temperature increases the skin's sensitivity to the damaging effects of pressure, shear, and friction, which all constitute key risk factors in pressure injury development. So the microclimate is extremely important for patients, so that we don't have them laying there in a very moist, hot environment. As we've discussed, MASD includes intertrigo, peri-wound skin damage from wound exudate, and peristomal skin damage from effluent, as well as IAD from urine and feces. Often it is incorrectly classified as a type of pressure injury, which sometimes it is not. So the etiologies of IAD and pressure injuries are multifactorial. IAD results from top-down damage, top of the skin down, tissue intolerance, age, nutrition, affected perineal environment such as incontinence, and obstacles to toileting such as restraints, inability to get to the toilet, and cognitive impairment. So the etiologies and pressure injuries of IAD and pressure injuries are multifactorial, and they are very different. So in contrast, pressure injuries can be both from the bottom up and the top down damage. Moisture from incontinence and perspiration increases the vulnerability of the skin and superficial tissue layers to pressure-induced blood flow reduction. So moisture weakens the skin and makes it more vulnerable to the effects of pressure and shear. So, but pressure injuries are much different than your IAD. So there was a study done, a systematic review and meta-analysis of incontinence-associated dermatitis, incontinence and moisture as risk factors for pressure ulcer development. This was done in Belgium in 2014 by the Faculty of Medicine and Health Sciences at Ghent University. Their aim was to identify the association between IAD, its most important etiologic factors such as urine and incontinence and moisture, and pressure injuries. And there's a list of the people who were in that study. From this study, it showed that there is a significant association between double incontinence and pressure injury development. We knew that, but studies do show that, so that's important that it is very significant. It also showed that urinary incontinence is a significant predictor of pressure injury development. And urinary incontinence proved to be the significant predictor of pressure injury incidence in 4 different studies where patients were pressure injury free at the start of the study. So they've done a lot of different studies on this. So 4 out of 5 studies showed that fecal incontinence was a significant predictor of pressure injury development. Five of 9 teams examined this association and reported significant association. So it's just proven that, yes, it does. So in conclusion, there is an association between IAD, its most important etiological factors, and the development of pressure injuries. So there's proof. We've all known that, but there is proof. Ammonia from urine and the enzymes from stool can disrupt that acid mantle like we talked about, eventually causing the skin to break down. As with the other forms of MASD discussed earlier, maceration also plays a key role in the formation of IAD and can make the skin more susceptible to friction. So wearing an absorbent brief or pad for a prolonged period of time can cause damage to the skin as well. So think about how the skin looks if you had a Band-Aid on your finger and you take it off and you see that, after a while, and you see that kind of whitish looking area that's wrinkled, moist and thin. Okay, well, that is the same thing that happens when people wear those briefs for too long a period of time. Incontinence briefs and pads have a similar effect on the skin, so you want to make sure that they're getting changed frequently, especially with patients who come to you that are not hospital bound. And also, here is the best environment for candidiasis. More prone, people will get candidiasis from stool and urine mixed. I mean, that is just the perfect combination for a great yeast infection. Candidiasis is Candida albicans. It's the most prevalent cause of fungal infections in people. Its species name, albicans, comes from the Latin word meaning white. The yeast appears white when it's cultured, and also you can see it on the patient as well sometimes. And in the case of certain infections such as thrush, you see that. So Candida albicans is part of our natural flora, our microflora, the organisms that commonly live on our bodies. So we all have it. It can be found in the GI tract, in the mouth, in the vagina. Most of the time it doesn't cause any problem, but it is possible for overgrowth and infections to happen. Candida albicans is the most common cause of genital yeast infections. Normally, a type of bacteria called lactobacillus levels, it keeps the amount of Candida in check. But when lactobacillus levels are disrupted in some way, then Candida can just overgrow, and then that's when you get the infection. So it's very prominent. I mean, it happens a lot. Here's some good pictures of it. It looks like a red rash with satellite lesions, and that's how we describe it in the charting. It's red rash, satellite lesions. When you see those satellite lesions, you pretty much know that's going to be yeast. Candidiasis occurs in areas of intertrigo, like you can see here under the breasts and in the folds of the skin. It can take on many different appearances. Sometimes it looks like you saw that hospice patient. It just looks smooth, but it's very painful. Usually either an antifungal powder used twice a day in these areas will take care of it. Sometimes it's bad enough to require diflucan or some other oral medication to eradicate it. Moist, warm areas is where it usually occurs. And again, you want to keep these areas clean, dry. Use something in between so that they're not sitting skin on skin. So this is another one of those things that you can usually smell a mile away. So you want to prevent it. Keep the skin, like I said, clean, dry, protected, moisturized. Never put more than one pad under a patient in bed. Use adult disposable briefs for ambulation only. and change the dressings based on the amount of exudate. Use correct pouching to prevent peristomal injury as well. And that is the end of my part of this presentation, and I thank you all for listening and hope you get something out of this presentation. There are references available to you, and now I will turn it over to Brooke.
Great, thank you so much, Kelly. What a terrific presentation. If you don't mind, I see you've got the next slide up. So if you enjoyed, if you enjoyed today's webinar, if you registered as a healthcare professional, CE credit certificates will be emailed to you within 5 to 7 business days. If you don't receive your CE certificate, please check your spam folder. You can also reach out and contact us at marketing@shieldhealthcare.com so that we can assist you. Next slide, please. Great. And if you haven't checked out our community, you can find more educational information like today's webinar on Shield Healthcare's online community. That's shieldhealthcare.com/community. Our community site has more than 2,000 educational articles, videos, lifestyle resources, and recorded webinars, and much more. We update our community site several times a week, and we encourage you to come by and explore our resources. Again, that's shieldhealthcare.com/community. Next slide, please. Oh, perfect. We also have our annual caregiver contest that's underway. This is our 18th year of holding this contest. It's open to healthcare professionals and caregivers at home alike. And our topic this year is tips for finding life balance as a caregiver. So we encourage you to check us out. The URL you can visit is shieldhealthcare.com/caring. Okay, great. Next slide, please. And also, we do have several free educational booklets available to anyone and everyone at no cost. That includes Living Well with Incontinence, also Living Well with an Ostomy, our tube feeding guides, wound management guides, and much more. You can also find those on our community site. Next slide, please. Great, and here's some information if you need to contact us. You can reach us at Shield Healthcare here at marketing@shieldhealthcare.com, and you can also reach Kelly and Capital Nursing Education at capitalnursingeducation@gmail.com. Now we'll go ahead and take a look and open it up for questions. Please feel free to advance the slide if you like, Kelly, or leave it right here. We've got a lot of questions coming in, and we'll see what we can get to today. If we're not able to get to everyone's questions, we'll do our best to reach out to you one-on-one and answer your questions after the webinar. Just to lead in, Kelly, in what type of healthcare facilities do pressure ulcers and skin damage from incontinence usually occur the most?
Boy, I would say that's 50-50. A lot of them will occur in hospitals, inpatient, medical, surgical, and also in the skilled nursing facilities, there's several that will occur there. I mean, it does occur there quite frequently. But I don't know for sure. I'm not sure. And it is even could be people at home that just don't know any better and have no help too. So if I had to say one or the other, I'd say probably the hospital. Great, thank you.
Another question, do you have any recommendations for zinc paste removal?
The best thing that I know of is mineral oil. And I know in the skilled nursing facilities, they can use some mineral oil. It's baby oil, just baby oil. It works really well to take off the zinc oxide. I think that's the best thing.
Fantastic, thank you. Next question, why should we not use chucks with plastic backing?
Well, that has to do with that microclimate. When you have a plastic backing on there, that causes heat to build up on the skin. And when you have the heat building up on the skin, that causes, number one, can cause a great medium for candidiasis. It can, without breathing, the skin can definitely lose a lot of what it needs, the lactobacillus, to keep that candida in check. So that's one of the things. It's also very uncomfortable to lay on a very hot surface. And when you have that plastic on there, it just doesn't allow any breathing So that's the main reason, especially on a low air loss mattress. If you have a low air loss mattress, you have something circulating a little bit to help keep that microclimate in check and to keep it nice. And if you have plastic, it's not going to circulate to the patient at all. It's going to just stop at the plastic. So not good.
Great, thank you. Great question and great answer. Thank you. Next question. You noted to use adult disposable briefs for ambulatory patients. What should you use for non-ambulatory patients?
You know, the best thing, in my opinion, and that is a good question as well, the best thing, in my opinion, is something laying under them. Now, I've had some patients at home that I've had them buy incontinence pads. You know, incontinence pads, just the pad, will absorb a lot of fluid, and you can put just the tip of the pad. This is on people who are not mobile. The tip of the pad right underneath the perineum, and it will catch a lot of urine and keep it from going underneath them. And that's the goal, is to keep them from laying in it. Now, in the hospital, they use also, I can't remember the name of it. What is the name of it? I can't remember. That actually hooks up to suction, and those of you that know it will know it. It is for females, and you put it down near the, what is it called? I can't remember the name of it. Anyway, it goes to suction, and it does help to keep that urine off of them as well. So those are two things. The other thing is just to change them often. Just really change them often.
Great, thank you so much. And please feel free to back up the slide if you'd like to keep our contact information up there. You're welcome to do that. The next question I'm going to read is, could you please clarify, when you said that if a wound starts as a moisture-associated skin damage, then becomes full thickness, it becomes a pressure injury? I'm not sure if I misunderstood that. Thank you.
I think, you know, that was from the Wound Care Institute, and that they defined it. This is not the NPUAP, it's Wound Care Institute. They defined it as a pressure ulcer or a pressure injury if it goes beyond the, if it gets deeper into the sub-Q, then it becomes, because normally IAD is surface. Normally, I mean, it may get denuded, but it's not going to go down into the sub-Q tissue. So if it does, there's definitely a pressure component there, which would make it be a pressure injury. So just the friction, shear, and pressure causes pressure injuries. Those are the determining factors. So when you get the skin from IAD gets weakened and peels off, and you combine that with the pressure, shear, and friction, you end up with a pressure injury. So I think the caveat to take home is that if it's beyond the surface and it's down into a full thickness wound, then and over a bony prominence, then it is then a pressure injury.
Great, thank you. And I just have to let you know, we do have several more questions here. We'll hustle through as many as we can, but again, we'll try to get to all questions after the webinar if we're not able to answer them right now. A response did just come in that the device you were talking about, the previous question, the device for incontinence would be the PureWick.
Yes, thank you. Whoever that was, thank you. Yeah, PureWick, it's wonderful. It's a wonderful device. But again, that patient has to be still. They can't be confused. They can't be combative. They have to be able to lay there still and let that work, because it can be dislodged pretty easily.
Great. Okay, the next question. What is the best antifungal cream or powder?
Oh, my favorite is nystatin. I can't help it. But there's also some out there. Remedy has an antifungal powder that we have used in the hospital, but really 2% miconazole, any one of the powders that is 2% miconazole is the best you can get. I'm not fond of the creams. I'm just not. But again, If they contain 2% miconazole, that's what you can, the best you can get.
Great, thank you. See if we can squeeze in one or two more quickly. Are you able to please define top-down and bottom-up damage?
Oh, well, when you think about the IAD being from top down, that means the top of the skin going inward. So in other words, it starts at the top, which means the surface of the skin. So IAD starts at the surface, and pressure injuries start usually on the inside at the junction of the bone and the tissue. And the reason for that is because that's where the most pressure is that causes that tissue not to have circulation at that area, and it will sometimes, most of the time, start at the bone level. So by the time you see it, the damage is already done. Hence the old, what they always say is the tip of the iceberg. By the time you see that pressure injury happening, that is the tip of the iceberg, because it is down below that the damage is actually done. So a pressure injury can also be from top to bottom in the way that you start with IAD over a bony prominence, add that pressure to it, and it's from the top of the skin down inside as well. But most of the time, a pressure injury starts way down deep and then comes up. So by the time you see it, the bad ones, they've already done their damage on the inside. Hence the DTI, that starts way deep, and by the time you see it, it's a huge wound. And then it opens up to usually a stage 4. So stage 2s, it starts way deep down below the dermis or the epidermis, and it is from that lack of circulation in the dermis, or the lack of circulation in the dermis can cause a stage 2 pressure injury.
Great, thank you so much. I'm going to read one quick comment, and then we'll do the last question we'll squeeze in today. Another comment that came in that the other female, this is going back to the Pure, which we talked about earlier, the other female external urinary containment device is the PrimaFit. It's more versatile since it's secured in the pubic area. We use PureWick, but we will explore the PrimaFit. So just wanted to toss that out there as well.
Oh, wonderful. They came out with another one. That's great.
And just last question to squeeze in this morning, will wearing pull-ups be bad for the skin?
I'm sorry, wearing what?
Pull-ups? Will wearing pull-ups bad for the skin?
Not usually. If the person is ambulatory and they are not confused to where they would leave it on too long, usually with that type of brief, it's not going to be bad as long as they take care of their skin. That is clean, moisturize, and protect. And changing it often so that you're not sitting there in that moist environment is the best way to protect the skin from that. And the other thing too, I just need to add to that, is when you use a moisture barrier cream, and this I've seen it happen so many times. If you use too much of it on the skin, it will render your pad non-absorbent. Because if it gets on the pad, then of course, it's not going to absorb anything because it's a moisture barrier. So you have to be very careful with that. I've seen some people, one time I saw one girl do this, where she said that she couldn't keep the moisture barrier cream on the patient's bottom. So she put it on the pad really thick, and then put the pad on the patient, and then complained that the pad was not absorbent. So moisture barrier cream does a really good job of protecting from moisture, but again, you have to be careful how much you use when you're using a pad. I think pull-ups are great for the people that are ambulatory. I think that's a great product. I hope.
Great, thank you.
Okay.
Great answers and great questions. Thank you so much, Kelly. Thank you for a wonderful presentation. Thank you, everyone, for taking time out of your day to join us. We'll wrap it here. This webinar has been recorded, so if you missed any portion and would like to recommend it to a colleague, you can find it within the next 24 hours, uploaded to shieldhealthcare.com/community. Have a great rest of your day, everyone, and thank you very much.
Thank you, Brooke.